Good morning, everyone. Welcome to our October edition of Sunday Mornings with Twitchy Women. We are very excited to have Dr. Jori Fleisher here today. I'm going to introduce her in a minute, but I just want to share a couple of little quotes with you. I was cleaning out books this weekend. My desk is a total disaster, and I'm cleaning out things. I found this adorable little book called Shoot for the Moon, and there's all these wonderful little quotes. It's got to be 20 years old. And I just want to read a couple to you because I think they apply to many of us. If you shoot for the moon, the stars are within reach. The road to success is always under construction. If you change your attitude and your perception of the problem will change. Think about that. Change your attitude. And we'll do one more. Let's see. Leave old baggage behind. The less you carry, the farther you go. And maybe I'll read a few more next time. So I hope that these inspire you to move forward and think about your attitude. Attitude is very important. And if you read my blog post that went out yesterday, that's what I talk about. So I encourage you to take a look at it. So welcome, Dr. Fleisher. Jori Fleisher is an associate professor of neurological sciences at Rush University Medical Center in Chicago. She's a movement disorders neurologist who leads the Rush Advanced Interdisciplinary Movement Disorders Supportive Care Clinic. That's a lot of words. The Cure PSP Center of Care, Rush Lewy Body Dementia Association Research Center of Excellence, and co-directs the Rush Parkinson's Foundation Center of Excellence. She completed her neurology, global health equities, movement disorders training, and a master's of science in clinical epidemiology at Penn, and she has additional training in palliative care, health services, and information research and advocacy leadership. She serves on the editorial board of Brain and Life magazine. Supported by the National Institute of Health, foundations, and philanthropy, she has several studies underway focused on designing and implementing novel models of care and support for individuals and families living with advanced movement and neurodegenerative disorders. In other words, she's way too smart for the rest of us. So we're looking forward to your talk, and I'm going to turn it over to you.
Thank you so much, Sharon. Thank you for the opportunity to speak to you all. And thank you, Ellie, for running things in the background, and to all of you for joining and sharing your morning, your early afternoon. Let me go ahead and see if this shares. Of course, Zoom updated. So we'll make sure it goes through. Can everyone see okay?
Yeah.
Okay, wonderful.
Good.
So I had heard from several of the people who I care for about the amazing Twitchy woman. And so to be on this webinar with you all today is so special, and I'm so honored. So I wanted to speak today about care partners. So I know many people joining may be living with Parkinson's themselves. Hopefully you have someone who you would consider a care partner, a caregiver, a carer in your life. I'll use those terms interchangeably. And so this is kind of a talk about what they go through and kind of how our system is designed right now to not really support care partners, and how my team and many others out there are trying to design better interventions, better programs, so that care partners are not so alone. Because if we take nothing else away from this talk, basically, people with Parkinson's and people with Lewy body dementia, and I'll clarify the differences, but you do best when you have an awesome supported care partner. We know that folks who don't have a care partner, or folks who have a care partner who's so stressed, so strained that they kind of can't tell up from down, those people with Parkinson's are actually more likely to wind up running into complications, going into a nursing home earlier. So the better we support people with Parkinson's, the better we support care partners, the better everyone does together. So with that said, we will talk about what is Lewy body dementia. Why am I bringing this up on a Parkinson's forum? What do we know about Parkinson's disease and Lewy body caregivers? And what can we do to support caregivers and those they love? So I'm going to walk you through some of the research that our team has done in the past, and then a really exciting study right now that is open to enrollment. and is supported by the National Institutes of Health. It's one of the first of its kind for care partners. So before we do that, what is Lewy body dementia? So bear with me. I really love analogies, and usually the kookier the better. So this is a chicken and egg under an umbrella problem, okay? So Lewy body dementia is an umbrella term, and it covers two different disorders, two things that we would consider synucleinopathies. So two problems in the brain where this protein called alpha-synuclein goes awry. And those two different disorders are dementia with Lewy bodies and Parkinson's disease dementia. So we might refer to those as DLB, dementia with Lewy bodies, Parkinson's dementia, PDD. And there are ongoing arguments. My movement disorder colleagues and cognitive neurologists love to spin their bow ties and decide whether this is all the same, whether it's a spectrum, are they two different conditions? It's a lot of lumping and splitting of diagnoses, but it becomes a which came first, the chicken or the egg. And I'm going to explain what that means. Okay. So if someone has Parkinsonism, by which I mean slowness of movement, trouble with dexterity, maybe a tremor, changes in their walking, changes in the stiffness of their muscles, or falls, those motor symptoms that we think about as Parkinsonism. If people have those motor symptoms, and then at least a year later, for many people, many, many years later, they go on to develop dementia, we call that PDD, or Parkinson's disease dementia. The Parkinson's comes first, and it's a very specific kind of dementia. This isn't Alzheimer's. This is something that is specific to Parkinson's. So changes in attention, concentration, multitasking abilities, trouble finding the right word when you want it. It's right at the tip of your tongue. You see someone, you're like, oh my gosh, I know who they are. This is so embarrassing. Why can't I think of their name? And they walk away. And then 5 minutes later, the name comes back to you. That can happen with normal aging, but that is something that happens more with Parkinson's as time goes on. And the other parts of the Parkinson's disease dementia are sort of these fluctuations where one moment someone could be really sharp, really spot on, you're able to have a conversation, you feel really good. And then 5 minutes later, it's almost like this cloud of brain fog descends. And you may be aware of it and just think, I can't get my words out. I can't think straight. I just feel foggy. And if you're a care partner, you may actually look at your loved one and go, oh, I can see like now is not the time to have a conversation. You can almost see the fog roll in and see when it clears. And that fluctuation is a hallmark of this kind of dementia. And the other thing that can go with it are hallucinations. So the movement stuff comes first, the dementia stuff comes later. That's Parkinson's disease dementia. But there are folks for whom that same kind of dementia, the fluctuations in cognition and alertness, the hallucinations, the trouble with attention and concentration, that comes first. And then later, they develop the movement symptoms of Parkinson's. Or all of it can start around the same time, within 1 year of each other, is sort of this 1 year rule that someone came up with. So whether you have the chicken of Parkinson's and then the egg, or the egg and then the chicken, or the egg and the chicken all coming together, if it's the latter, we call it dementia with Lewy bodies. But if you have Parkinson's disease dementia or dementia with Lewy bodies, you've got both the chicken and the egg, regardless of which order they came in. We call that Lewy body dementia. And you might think to yourself, that is literally just rearranging these words in a different order. Why is that something different? I agree with you. It is terrible naming. It's super confusing. It's super confusing to my colleagues. People will use the terms interchangeably. We need to do better. But suffice it to say, Lewy body dementia covers everyone if they've started to have those cognitive changes. And for whatever reason, and this will explain why the studies that I'm going to tell you about shifted from just Parkinson's to Lewy body, is that there was legislation passed in Congress to dedicate more research funds at the federal level through the National Institutes of Health, which funds the most research in the country, that there's more money allocated to Alzheimer's and Alzheimer's related disorders. And whoever designed this, it was not me, Lewy body dementia, the umbrella term, falls under that extra level of funding, but Parkinson's alone does not. Okay, so if you were a researcher and you wanted to design something for the patients and caregivers who you see and have a better chance of it getting funded, you apply under the Lewy body umbrella because that covers more people and has a better chance of actually getting funded. So that's a little bit of a peek behind the scenes. But we certainly can diagnose dementia with Lewy bodies. For the sake of today, I'll probably skip through this, but I mentioned that there are certain features that need to be there to make this diagnosis. And so there are a lot of people out there who are told initially you have Parkinson's, but actually when we sort of listen later, we say, you know what, it sounds like actually everything was kind of happening all together around the same time. Sometimes it's hard to pinpoint when some of the cognitive changes started. And so sometimes we revise the diagnosis and say, actually, I think this might be dementia with Lewy bodies, not straightforward Parkinson's disease. The symptoms are all the same. It's just a question of timing. Um, and one of those symptoms, as I mentioned, is hallucinations. And this can happen in Parkinson's and in Lewy body. And so sometimes those hallucinations can start as just a blip of color, like a little flasher or a floater. And you might wonder, well, how do I know if it's not coming from the eye, if it's an ophthalmologic problem? We don't unless we test it. So if you're seeing flashers or floaters or little splotches of color, absolutely a great idea to go to your eye doctor, be tested, make sure that there isn't something treatable on that end. But if not, it may be an early hallucination. And so the brain just kind of flashes these little things. And often people with this will recognize, oh, that's not real. They kind of blink and it goes away. As time goes on, those hallucinations can evolve and typically can become little animals, things that are not scary. So it might be seeing a little mouse in the corner, which I say that and recognize if I saw a mouse in the corner of my house, I would be scared. But it could be, kids playing out on the front lawn who aren't actually there. They can be things that could be realistically happening. So oftentimes a person with Parkinson's who's having these hallucinations may not say to their care partner, hey, I'm seeing little kids on the lawn, because there very well could be little kids playing out on the lawn, or there could be a little bird at the window. And then they kind of blink and look again and it goes away. As time goes on, those hallucinations can get more complex. So we can have people who see groups of people in their home. They can become more frightening. They can become sort of more intrusive. And people lose the ability to say, oh, that's not real. So it can become more frightening and a big source of agitation. This is actually something that winds people up in the emergency room and in the hospital. And we have medications that can help treat hallucinations. What we need is better education for people with Parkinson's and for care partners to recognize when this is happening early so we can try to avoid the crisis, right? And we can kind of try to treat when things are easily treatable instead of waiting. I really love this painting. This was actually published in an article in Neurology, our main journal, by a doctor, Dr. Stephen Frucht, who's a very famous movement disorders neurologist. And his co-author, Mr. Bernson, actually was a very well-respected artist, had Parkinson's himself. And Dr. Frucht asked him, do you think you could paint a picture of what your hallucinations look like when you're having them? And so we have this really beautiful illustration of kind of all of these people, and it's kind of vague, and they're moving into each other, but just this idea of kind of feels real and not real at the same time. So I mentioned that hallucinations are a big problem. And hallucinations are listed as one of the things that when we look at research studies that say, why do people with Parkinson's or why do people with Lewy body wind up in the hospital? So the leading causes of hospitalization are falls, especially falls that lead to a fracture or broken bone. Urinary infections are, in my mind, number 1, 2, and 3. Dehydration or metabolic changes, and then neuropsychiatric issues. So those hallucinations getting out of control, delusions where someone thinks that a loved one is not who they say they are. That's a very common delusion. Other forms of paranoia, agitation, depression, and anxiety. Those are all reasons why people with Parkinson's may wind up in the hospital. And separately, and I think this is, really, really important to cover, is that when we look at who winds up in the hospital, we can also look at studies that have evaluated caregiver strain. There are a lot of different surveys to measure sort of how pulled in different directions does a caregiver feel? How out of control do they feel in terms of being able to help their loved one? How much do they feel is weighing on their shoulders? And even if we adjust, we do all kinds of fancy statistics and say, accounting for people with Parkinson's whose disease is more severe, we can say that caregiver strain alone is a major risk factor for the person with Parkinson's winding up in the emergency room and in the hospital, which tells us that, yes, if we could prevent falls, we could keep some people out of the hospital. If we could catch urinary tract infections early, we could keep people out of the hospital. If we could manage the hallucinations, we could keep people out of the hospital. But if we can do better for our caregivers, that also will keep our people with Parkinson's better and out of the hospital, right? And here's the problem with the hospital. I work in a hospital. It's a wonderful place if you need to be there. And also, as someone who cares mostly outpatient, I don't want any of my people winding up in the hospital if we can avoid it. People with Parkinson's and people with Lewy body dementia have longer hospitalizations, more complications, and are more likely to be discharged to a nursing home than the same aged person coming in with the same problem who doesn't have Parkinson's. So if you have two 70-year-old women both coming into the hospital with a urinary tract infection, but one has Parkinson's, that lady with Parkinson's is much more likely to stay longer, to have more problems while they're there, and to wind up in a nursing facility instead of going back home where they want. So this led us to this hypothesis, this idea that many of these things, many of these causes of hospitalization, like I said, might be preventable or at least manageable at home if we can recognize them early. But that requires an educated, engaged, and observant caregiver. So what do we know about caregivers of loved ones with Parkinson's and Lewy body dementia? Hopefully someone has seen Encanto. Louisa is the older sister. She's my favorite character. I deeply identify with Louisa. Her superpower is she has super strength and she feels like she literally needs to carry the world on her shoulders. She is my avatar for all of our Parkinson's and Lewy body caregivers. So what we know is that our caregivers are overburdened and understudied. So in studies from the Alzheimer's literature, we know that about 83% of community dwelling people with Parkinson's or Lewy body rely on unpaid caregiving from family members. And what that equates to is 18.5 billion with a B, 18.5 billion hours of care every year, which if that were paid for would be over $232 billion, right? But this is spouses, significant others, adult children, neighbors who are like family, friends who are like family, coming over, helping, bringing someone to the doctor, taking them to the emergency room, helping to dole out pills, organize pill boxes, sort through what was it that that doctor said? That doesn't make any sense. Let's go online and try to figure something out. And among caregivers, even in early Parkinson's, there's a nearly twofold loss of direct income in the first 5 years of caring for someone. And we know that in studies that have looked at Parkinson's caregivers and Lewy body caregivers and compared them to caregivers of a loved one with Alzheimer's, people caring for a loved one with Parkinson's have higher caregiver strain, higher burden, and higher depression scores, their own depression scores, than caregivers of people with Alzheimer's. And we think that the reason for this is that although Alzheimer's is its own terrible diagnosis, it is largely a cognitive problem. Whereas Parkinson's and Lewy body are cognitive and movement and neuropsychiatric, the hallucinations, the delusions, the depression, the anxiety, the apathy that can come with it, the non-motor symptoms, managing constipation and blood pressure fluctuating and temperature fluctuating and sleep problems, all of that kind of wrapped up in one ball. And the only predictable thing for many people about their Parkinson's or their Lewy body is how unpredictable it is. We know that depending on your medication schedule and your disease, you may have motor fluctuations where you're good, you're moving really well, and then the meds wear off and you're not doing so well. And as I mentioned about those cognitive changes, you may be alert, working really well, thinking, talking, doing all the things, and then foggy the next moment. And we can't predict when all of those fluctuations will happen. And in fact, writing some of the studies that we had written and trying to make the point to peer reviewers, to other researchers, and saying, hey, listen, my caregivers who I see in clinic, my Parkinson's and Lewy body caregivers, they are different from Alzheimer's caregivers. And there's always reviewer two. We always joke that reviewer two is the one who's, very disparaging and says, well, why do you think this is special? I don't really believe in your findings. And we said, all right, we'll do a study to prove this to you. So in a study that we did with Lewy body and Parkinson's care partners as part of my research team, we surveyed care partners, just a really quick survey. And we said, which of the following categories of medical problems do you have, caregivers? And we asked for their age and we asked for the severity of these problems. And what we found in this table is it's kind of a kooky to read table. But if you look at this, this is all caregivers who answered our questions, all comers. This was 70 out of 182 said that they had high blood pressure, which is about 38.5%. So the percentage is in the parentheses. But if you look across the rows, every box that's a dark gray says that for people that age group, so here among our adults aged 65 to 74, 41.4% of those caregivers had high blood pressure. And the dark gray means this is a far higher percentage than people should have at that age. So we know blood pressure increases and it's more common as people get older, but this is out of proportion to what we would expect for age. And if we look at depression, nearly half of our younger caregivers, more than half of our 45 to 54-year-old caregivers had depression, way higher rates than we should see for someone that age. So this helped us to be able to go back to reviewer two and say, no, listen, things really are different for Parkinson's and Lewy body dementia care partners. They deserve better. You can't just lump them in with Alzheimer's caregivers and say it's all the same thing. If you come up with something that works for Alzheimer's, it'll work for people with Parkinson's too. That's just wrong. So we've been trying to do better. We also know that caregiver strain on its own increases the chance, as I said, of a person with Parkinson's winding up in the hospital and being placed in a nursing home. And to date, there are no Parkinson's or Lewy body specific caregiver interventions that have been helpful. Nothing so far has shown a lot of promise. Not much has been done, so there's lots of room for ideas. But in dementia, as sort of the bigger, more well-funded group, there are some interventions that have been shown to be helpful, but only those that are extremely expensive and that have, a nurse who's calling and checking in with the caregiver, 3 times a week. And then you go and you do a seminar in person and you practice different things. And that works for a caregiver who can afford to take the time and the travel time to do that, but not everyone can. And it's not specific to Parkinson's. And being able to sustain programs like that beyond a research study has proved really difficult. And so every day in clinic, I have caregivers that say to me, okay, Jori, I can't do this anymore. I'm finally ready to bring in some help. Send me a caregiver. And I have to tell them the following, which is that our healthcare system does not have a safety net for caregivers because paid caregivers, bringing in someone outside of the family, is not covered by insurance, including Medicare, and it's not even part of hospice benefits. Paid caregivers are extremely expensive. So depending on where you are, and this is US specific, so I know that we had someone joining us from London, hello, numbers will vary and healthcare systems will vary tremendously. But in the US, figure about $30 an hour for a paid caregiver or about $5,000 a week. And if you're in a high cost of living area, it could be double that. They are in very high demand and very low supply. And paid caregivers have very high rates of turnover and burnout. And this was true pre-COVID, and it's been worse since COVID. And caregivers have minimal or no training in dementia or Parkinson's or end-of-life care. So for all of these reasons, this is not a sustainable option for most people. Right. And so I'm not here to share the gloom and doom. I promise I'm going to leave you with hope, I think. But this is how our healthcare system is set up right now, is that there just is not a safety net for people when they need extra assistance. So this led my team way back starting in 2014 to say, what can we do to support caregivers and those they love? So Sharon, you are too kind about all of my training, but I really feel like the research that I do is kind of low-hanging fruit and the opposite of rocket science. It is meeting people where they are and just asking, what is it that would be helpful? And so back in 2014, I had the opportunity, I was on faculty at New York University for a few years, and I had a division chief who had gotten some philanthropic support to help find his patients who had been lost to follow-up. Mostly people with Parkinson's, but also people with dementia with Lewy bodies and some of our atypical Parkinsonisms. And he looked at me and said, "You're a junior faculty, you've got lots of energy, you seem kind of warm and fuzzy. We're going to go do home visits. Rather, you're going to go do home visits, build the team that you want, and go do it." And so, together with a social worker and a nurse, we went out to the homes. We did over 400 visits in people's homes all over New York City, all 5 boroughs. That is way too large of a geographic area for a home visit program. We spent a lot of time traveling. But what we did is my job was simple. I was doing everything that I would do in the clinic with any of my patients, asking questions. Are you falling? Are you hallucinating? How are your medicines working? Show me your taps. Let's do the claps. Let me see how you're walking. I'll wiggle you around. All of that's easy. The doctor portion of this was the least important. What was really important in our home visits was my nurse and my social worker and what they did, because too often we don't have access to a nurse and social worker. And so for people who were receiving home visits, these were folks who were either had multiple hospitalizations, they were missing a lot of appointments, they were really struggling, and they met the Medicare criteria for being homebound, which means it was a considerable and taxing effort to leave the home, and getting out of the house required another person to help them, special transportation, or a wheelchair or a walker. And so we went to them, and our nurse did vital signs. She checked blood pressure sitting and standing to see if they were dropping their blood pressure. She went to the medicines and said, "Show me how you actually do this. Not just are you taking what the doctor thinks you're taking, show me how you organize things, for better or worse." And we learned a lot. And then, with permission, we walked through people's homes. We had their permission to open the fridge and open the pantry and see that someone who was labeled in the chart as non-compliant with their medicines, they're not taking their levodopa the way they should, was actually trying to make a 30-day supply of levodopa last for 90 days because they were choosing between medicine and food, and there was nothing in the pantry. And we would only have learned that by being in their home and gaining trust and realizing, you know what? The most important intervention for this person is not some fancy form of levodopa. It's not considering deep brain stimulation. It's getting them Meals on Wheels. It's getting them food so that they can take that worry off their plate and that worry off their caregiver's plate, and they can actually focus on other things. And while our nurse was doing those things and looking at the bathroom for home safety and where are people falling, our social worker was sitting with the care partner, if there was one, not everyone had one, but sitting with the care partner and going, what services do you currently receive? And what services would be helpful? Have you talked about your loved one's goals of care? Have they designated a healthcare power of attorney that if they're unable to make decisions for themselves for some reason, who is making decisions for them? And does that person know that they're supposed to be that person? And do they know what that person would want in case of an emergency? And we would all come together. We would gather this information, do the taps and the claps and the walking and look in the pantry, put everything together and say, okay, here's our plan. Does this make sense? And what we found was that this worked really well for people with Parkinson's disease. So in our home visit pilot study, despite advanced Parkinson's, people who were receiving home visits did not have the expected decline in their quality of life that we tend to see in every other study of Parkinson's. Usually, as time goes on, function declines at a different rate for everyone, but function declines and quality of life kind of follows. But here we saw these were folks who were very severely affected by Parkinson's, but their quality of life stayed the same. And this was really encouraging. But among those who had a caregiver, and it was a small sample, those who had a caregiver who was there at home visit 1 and still there a year later at home visit 4, their caregiver strain was getting worse. So home visits were not going to be enough to help our care partners. And so what we did was we looked around at other research that was out there and wondered, could connecting caregivers together one-on-one ease this journey and the isolation? Could this actually be helpful? And we know that support groups and groups like this are tremendously helpful to people living with a diagnosis and to care partners. But what about one-on-one? There are a lot of people who are so overwhelmed that the idea of logging onto a Zoom at a specific time is just too much. They just don't know if they're going to be pulled in a direction, or they're too shy, they're too introverted, there's so much stigma, they don't want to be part of a group. And so what we found was this idea of peer mentoring. So initially this was done in Alzheimer's disease caregivers, where organizations recruited former caregivers who had lost their loved ones to Alzheimer's and paired them up with current caregivers and said, basically, talk to each other. Be a shoulder for this person to lean on. You've got knowledge, you've got lived experience. Tell someone else, see if that helps them. And the programs were very loosely organized. There wasn't really a curriculum most of the time. But what they found was when they did surveys and they looked at kind of numbers of are you better now, the numbers weren't so compelling. But when they asked people to talk about being part of a peer mentoring program, it was unicorns and rainbows, right? It was glowing and people loved it and felt this was so helpful. So in the last couple of years, many people have tried this idea of peer mentoring and found that this works really well because who can better advise you on what it's like to live with a condition than someone who's doing it? So people have studied peer mentoring among trauma survivors, among individuals with kidney disease who are going on to dialysis. They've tested peer mentoring among older adults who are very sedentary, who don't exercise, and pairing them with someone who used to be sedentary, but has taken up exercising and found that they are the best motivators to get someone up off the couch and onto the track, better than a personal trainer, better than a physical therapist. Young adults with neurologic disorders have mentored each other, family caregivers of people with cancer, and I think this is the most astonishing one is bereaved parents who have lost their children to cancer will willingly go back into that world and put themselves back in that emotional space to help other parents who are in the process of losing their children or who've just lost a child to cancer. And they've found that not only will people do this, but it helps the mentee, the person who's living through it right now, and it also benefits the mentors. So we thought, has anyone done this in Parkinson's? And they hadn't. We thought, well, let's give this a shot. So I was in the process of bringing the home visit intervention to Chicago, which is where I am now. And through a grant from the National Institutes of Health, we designed this home visit plus peer mentoring study. And we recruited 65 pairs, a person with advanced Parkinson's and their care partner. The person had to be living at home at the start of the study, and they got 4 home visits over the course of the year. And this was pre-COVID. We started testing out telemedicine. So my nurse went to the home, my research coordinator went to the home. We brought a little Wi-Fi hotspot. We brought our internet with us and an iPad. And so I was in my office to try to test, could we make this more sustainable? And we did all the same stuff that we had done in New York. We looked at meds, my nurse walked around the house, the social worker asked all the questions, and then we came together and we put together, a concrete plan. And we've published on this. But what we also nested in there was we said, all right, at home visit 1, we're going to get to know the person, get a sense of what's really happening. But then when we go back 3 months later for home visit 2, we'll check in, we'll see how everything's going, we'll do the examination, and then we will let the caregiver know we've trained a mentor who is willing to talk with you and just be that shoulder to cry on, be someone that you can turn to and say, what do I do? Is this normal? I'm feeling angry. I'm feeling guilty. I'm feeling hopeless. I'm feeling whatever it is. Did you ever feel this way? And they can share their own experience. And we thought maybe we should give people a little bit of like a guidebook or something. So we put together quite literally, I think it was all of 30 pages. This is the table of contents from that initial guidebook, stuff that we thought might be helpful. And so our mentors talked with the homebound caregivers. We asked them to speak every week for 16 weeks. And we just asked, did they actually do it? And so we had them keep a little bit of a diary. And so what we found was that Parkinson's caregiver peer mentoring was feasible. People actually did it, and they were really satisfied. So 51 out of 61 eligible caregivers enrolled in the peer mentoring. We had some people who opted out. Interestingly, the people who opted out and said, I don't want to talk with anyone, no one can have any idea what I'm going through, were the people who had the very highest caregiver strain. But among those who spoke with each other, they had an average of 11 calls in 16 weeks. We didn't tell them how long to talk. We just asked them to tell us how long they spoke, and they talked with each other for 30 minutes. And on average, on a scale of 0 to 100, they said that their satisfaction was 91 out of 100. And what we found was when we compared our patients over the course of 1 year and our care partners over the course of 1 year to a control group that was actually quite a bit healthier and younger, the control group caregivers, like in every other study of Parkinson's, caregiver strain worsens as time goes on, as Parkinson's goes on. But in our group, getting home visits and peer mentoring, caregiver strain didn't change. It stayed the same. So this was really encouraging. So as we were trying to figure out what's the next step for our home visits and how do we transition this, because then COVID happened, how do we transition everything we were doing in the home and try to find out a way to do that all virtually, not just during COVID, but beyond, so that this could reach people who aren't close to a movement disorder specialist. I thought, well, this peer mentoring piece, this might be something that we could do easily and virtually. And so we got more funding from the National Institutes of Health, and we partnered with the Parkinson's Foundation and the Lewy Body Dementia Association. And we came up with the word persevere. So this word means a lot to me. I grew up very close to both sets of my grandparents. And my maternal grandmother, Ro, she taught me the word persevere when I was 4 years old. I don't know why, but it became part of the family lore. And the word persevere in the dictionary says to continue in a course of action, even in the face of difficulty or with little or no prospect of success. And when you come up with a grant, usually if you want a catchy grant that people are going to pay attention to, you try to come up with some acronym. So persevere comes from peer mentor support and caregiver education and Lewy body dementia. And we pulled persevere out of that. And so what we did is we gathered focus groups first of folks who had been mentors in those home visit mentoring and mentees in there, and then people who were new de novo, so totally new to this idea of peer mentoring. We gave them the little 30-page handbook and said, is this enough? Would you want more? Is there something that would be helpful that you don't feel like you're getting from your healthcare team or from looking online? And they said, oh boy, write this down. And we went from, I'll show you this in a moment, we drastically expanded our curriculum. We made the intervention entirely virtual, so people could join from all over the US. In partnership with LBDA and with Parkinson's Foundation, they emailed their listservs, they posted it on Facebook. And so we recruited 36 new mentors, so people who were either still actively caregiving for a loved one, but had been doing so for at least a couple of years, or they'd lost their loved one, and they were willing to serve as a caregiver for someone else. And that mentor training looked like about 6 hours online, just like this, covering really key topics in Parkinson's and Lewy body to give everyone kind of the same playing field. So maybe your loved one never experienced hallucinations, but in case your mentee's loved one does, we want you to know what that looks like. We trained people in active listening, how to be a good mentor, how to set boundaries, what to do in case a mentee said, you know, I'm feeling really hopeless. I really don't know where to go from here. I kind of wish that I would go to sleep and not wake up. So we have lots of safety protocols in place, and we offered lots of support to our mentors. So they actually met almost like a support group once a month so that they could touch base with each other and share successes and challenges. And we recruited a bunch of new mentees. And even though in prior mentoring studies, in the Alzheimer's studies, they said it doesn't really matter how you match up the mentors and the mentees. If you match people up by the same gender or anything like that, it doesn't actually make a difference. We suspected that that wasn't true. And so we asked our mentees, sort of caregivers who are within the first couple of years of caring for a loved one with cognitive change, we asked them, of these things, gender identity, age, racial or ethnic background, same role. So how important is to you to be matched with someone who's a spouse caregiver or an adult child caregiver? How important is it to you to be matched with someone whose loved one has passed, who's gone through the grieving experience? How important is it to you to be matched with someone who's geographically close to you in case you wanted to get together? We asked people to kind of rate each of those factors, and then we put those all on index cards and we matched people up and tried to make the best matches that we could. And we actually did a pretty decent job, we think, of matching people up based on their priorities. And like I said, we had this tiny little 40-page book, 30-page book for the first version of the study. In the second version of the study, in Learning to Persevere, we heard lots of feedback and people said, include all of this. And so we made different modules, and each week or 2-week block was a module that included a social support topic and Lewy body topic. So some weeks included things like depression, anxiety, and apathy. Some weeks included resources for aging in place. How do you find a caregiver? How do you hire a caregiver? How do you make your home safer? How do you prevent these things from happening? How do you advocate for your loved one in the emergency room? We really drastically expanded and went from a 30-page book to an almost 400-page book. You could bench press it. And what we found was when we asked people to talk with each other, again, we didn't give them a timeline of how long to talk. There were 424 calls over 16 weeks, about 15 calls per pair, and they talked for an average of 45 minutes. Some of our pairs talked for 2 hours every week. They just hit it off and found that they had so much to talk about. When we asked at the end, did you find this useful? Would you recommend this to other caregivers? 100% said yes to those. And what I think is most encouraging is knowing that until our healthcare system changes, right, the cavalry isn't coming, right? There's nothing else out there right now. Could this be a pipeline? Could this be something that's sustainable and generations of caregivers can help each other? It's not everything that we should have. We need to do better. But could this be something that kind of sustains over time? And we found that when we asked our mentees, would you do this program again? Would you go back through it as a mentee? 40% said, yes, I'd do it again as a mentee. I feel like I have more to learn. 10% were like, I'm good for right now. But 50% said, I would become a mentor for the next group to come through. I'm ready to pay it forward. And 90% of our mentors said, keep me on your list, coach. Call me in off the bench. I'm ready when you need me. So to me, those are the most compelling figures. But what we also did was we tested change in knowledge, in attitudes, in confidence, in skills as a caregiver. And we found what we expected, what we hoped was that our mentees would improve. And they did. But we also found that our mentors, some who'd had 15 years of caregiving experience, they improved as well, which was really mind-blowing and reassuring to me. And for the sake of time, I won't talk through all of this, but we got a ton of feedback. So many people feeling like, I wish I had been given this book the moment my mom was diagnosed. It would have saved a lot of worry and tears and frustration, and just validation for our mentors saying, I didn't really recognize how much I knew and how much I could help someone else. And to be able to do that was tremendous. And again, we got so much feedback from our folks, and they said, this is all good. We love having this book, but I don't want to bench press and schlep something around that's this heavy. Make it digital, make a PDF, make a website, add more information. We need more information on nursing facilities and hospice and grief and brain donation and burnout. So we thought, okay, we keep thinking, are we there yet? Are we ready to launch a really big study? We paused. We got more feedback from people. We restructured how we did it all. We incorporated some really cool virtual reality technology that's designed for care partners of people with Lewy body dementia to kind of see what the world looks like through the eyes of someone with Parkinson's dementia or Lewy body dementia. And so we tested that out. We showed that in focus groups to care partners, and we were like, good, bad, do you like it? Do you hate it? Is it too triggering? Who should see this? And they said, include it, put that in, add more. We tested a website. They loved it. We've built it out even further. And so with all of these step-by-step studies, I applied for funding to the National Institutes of Health for a big independent researcher. It's the big girl pants study. And lo and behold, they funded it. And so this is our beautiful logo that my research assistants created. So persevere. First, we learned to persevere. Now we're actually persevering. And it is a national randomized controlled trial of this intervention. And so the question really is, can a Lewy body specific, caregiver-centered educational intervention improve our caregivers' knowledge and confidence and strain and their own health outcomes? And can it help their loved ones as well? And so I'm not going to talk you through this big ugly diagram. Suffice it to say, there's a lot of psychology and cognitive models of how do we change behavior and what levers do you need to pull and what do you need to include and how is this going to work? And the different surveys that we asked at different time points in the study are because we think some things may change earlier and some things may change later. But what this study looks like is it is entirely virtual. No one has to be in Chicago. I know some of you on the line are. That's wonderful. Hello. But this study is open to people throughout the United States and US territories. So hello, Puerto Rico. Hello, Guam. You are welcome. We have resources for you. And it's open to both current and past family caregivers of a loved one with either Parkinson's dementia or dementia with Lewy body or Lewy body dementia, or even if you are caring for a loved one with Parkinson's who doesn't have a formal diagnosis of Parkinson's dementia, but your loved one is starting to have hallucinations or starting to have cognitive changes, we want you. We want people early in the course of this so that we can intervene early and give you the information that we hope will be helpful going on. So we're recruiting our two different groups of folks, are experienced, either 3 or more years that the loved one has had cognitive change or who've lost their loved one. We will recruit you as peer mentors. We will train you and you will be matched with up to 3 mentees over the course of the next 2 to 3 years, one mentee at a time. It's about, an hour or less a week after we do the training. The training is all online as well. And then once a month while you're mentoring, there's an active kind of check-in Zoom. And then our caregivers, our bigger group, are caregivers who are newer to the cognitive changes of their loved one. And they will be randomly assigned. Half will be assigned as mentees, so they get access to the whole curriculum for Persevere, and they're matched with a mentor. And then as a randomized control study to prove that this really works, unfortunately, we need to have a control group. And the NIH said, well, why can't you just randomize people and give them nothing? That's scientifically, the best way to do a control group. And ethically, that does not fit well with my soul. And so our control group absolutely gets intervention. So we've just pared down the curriculum. So it's a slightly less intense curriculum without the mentor, and people are randomly assigned to one or the other group. But this will help us tell whether this is actually working. And so I kind of talked through this, but everyone gets sort of an intro webinar that we've created to give everyone kind of a level playing field. And then the people who are assigned to the mentee group get the full curriculum, the website and all of this stuff and links to existing resources. We've done a lot of work for several years looking online at everything that's out there relating to Parkinson's and Lewy body, all of the Parkinson's Foundation content and Lewy Body Dementia Association and APDA and Michael J. Fox and all of these different things, making sure that the links are still active and which one is a really good explanation of hallucinations, which one has a really great explanation of apathy, who talks about caregiver strain in a way that really makes sense, and trying to put that all together. And so those resources are included every week, regardless of which group that you're in. So we give people sort of a, here are the things that we think should be on your reading list. Not a ton, but stuff to kind of be able to reference back throughout the course of caregiving. And we touch base with folks every 2 weeks through like a very quick, brief survey. Either we text you or we email you at your preference, remind you to fill out this quick thing, let us know, did you do your reading? Was it helpful? Was it not helpful? Which ones are useful or not? And we touch base with folks. We send them updates because personally, I feel like the person who needs to hear the results of research first are not my colleagues at a conference, and it's not someone reading a scientific journal. It's the people who participated. So we get our results once we have all the analyses. It is our participants who will learn that first. Every month we send out updates, just letting people know here's where we are with enrollment and here's some really cool stuff going on in the community. Check out the externally led patient-focused drug development group that LBDA is holding. Check out, Moving Day is coming to a community near you. Go walk, go do these things. Trying to keep everyone sort of in the loop. These are the topics that we cover, but I kind of showed you those before. We talked through the different criteria, but most importantly, we recognize that in most studies of Parkinson's, in most studies of most health conditions, unfortunately, most of the participants are highly educated, highly connected to the healthcare setting, and tend to be not from minority backgrounds. And so we are certainly open to everyone. And in particular, we are really trying to reach our caregivers of color, our Black, our Latinx, Hispanic caregivers. Male caregivers are really underrepresented in Parkinson's. And our rural dwelling folks. We know it can be so hard to find things if you're not at a major metropolitan area. So if you know or are connected to communities in either of those groups, please feel free to share information. And so is there a link? Is there something I can join? Absolutely. So here is all of our information. So enrolling in the study, finding out more about the study, it is all online. You can go to this link over here, Persevere 1. You can scan the QR code. It will take you all to the same place. There's a video on there of me talking through some of the same kind of stuff. But through there, you can see if you're a caregiver, if you qualify. And the way that this works is people go through the survey, it pings my team, and then we will reach out. Before anyone enrolls in the study, they actually have a live phone call with one of my research assistants to make sure that all questions are answered. You totally understand what you're signing up for. And then you fill out the consent forms online and sort of go through all of the rest of the steps. So with that, and I'm happy to share slides and flyers and all kinds of info, but I hope that I've shared with you that Parkinson's and Lewy body family caregivers have higher strain and burden than caregivers for individuals with Alzheimer's. That caregiver strain is a risk factor all on its own for the person with Parkinson's winding up in the hospital or a nursing facility, but there are potentially modifiable things, and that this may be doable with a peer mentor-led educational intervention. And despite high strain and burden, our caregivers hold and willingly share their invaluable lived experience and can train as mentors to newer caregivers who improve their own knowledge and attitudes and then want to serve as future caregiver peer mentors, creating a pipeline until we have a better system. So with that, thank you so much for the opportunity to speak with you. I want to acknowledge all of the amazing people I get to work with and who coach me along on the way and have helped shape this project. Not only my mentors, but my mentees who I learn from all the time. We have amazing donors who have helped support this work to get to where it is and continue to support it. My kids who help me look to the future and say, you need to build better, what's coming next. And these are my maternal grandparents. And as much as they taught me to persevere, they also persevered tremendously. They raised a child with severe neurologic illness, and they showed me what persevere means on a daily basis. And unfortunately, my grandmother, Ro, lived with and passed from Parkinson's disease last year, and my grandfather lives with dementia with Lewy bodies, all of which were diagnosed after I went into this field. So this work is deeply meaningful to me. So I really appreciate the opportunity to share it with you and all that you do in your communities. So thank you so much.
Thank you. This is amazing. We have our own mentoring program that we started several years ago. I'm not sure if you're aware of this, and Ethel is one of our amazing mentors. And we have, are anybody else online a mentor? I know Eileen Menton is on. She's also a mentor. She went from being a mentee to a mentor. Anybody else? But we have not done the research you did. We put together a program within 3 months and got it up and running after the pandemic, mid-pandemic, and we realized that people were desperate to have someone to talk to. And Ethel and Eileen, I think you can attest to the fact that people really do better when they have someone to talk to, right? Yeah. So I think this is amazing. I think mentoring programs have become more common, I think, throughout many different medical communities. You know, all the different diseases. We actually worked with Sharsheret, which is a breast cancer survivor organization, and we worked with them because they had already developed a program, and we used a lot of their materials and adapted it for our use. But we don't do the amount of training that you do. Anyway, any questions?
Darren, I have a question.
Okay.
Can you go back to the scan page? She said she wanted to get the word out in the minority communities, and I'll put it out if I get the scan page.
Absolutely. And I can, we have a flyer that has it on there, so I can send that to folks too.
That'll be great. Thank you.
Well, I copied that page, I think. Yeah, that one. Okay.
Here's the link if that's helpful.
I made a screenshot of it. I can put it in the chat, I think.
Thank you very much.
I'm sorry to run so long.
It's okay. Any other questions? Okay, if you can take yours down. Okay. Ellie, do you want to put the slides back up? Oh, Denise has a question. Go ahead, Denise.
That was my question to get the scan.
Oh, okay.
Thank you.
All right, so let's do our next slide. So our next program is October 6th, so 3 weeks from today, I think. Bunny Dibness, who is an elder care expert, will be talking about where can you go when you're ready to move out of your house. There are a lot of options and where you can get help. And I think it will be a very interesting program. Many of us are staying in our homes as long as we possibly can, thinking that the next step is a nursing home. It's not always that case. So there are a lot of options, and she will be talking about that. Next slide. I'm doing a very informal survey on people who have been diagnosed more than 10 years. It's just a short survey about the progression over the years. And it's not going to be funded by NIH or Parkinson's Foundation or anybody like that, because it's definitely a non-scientific study. But it's really about how we as people with Parkinson's see why we are doing well or not doing well after so long. Those of us who were diagnosed more than 10 years ago, there were very few resources. Many doctors gave us no information. Exercise wasn't on the table. Things have changed quite a lot in the last 10 years. So we will, if you're interested, just send me an email, or I believe, did we put it in the chat, Ellie? I don't remember. Go ahead, next slide. Okay, so here's our peer support program. And we really need mentors. If you have been diagnosed 3, 4, 5 years ago and you want to help somebody else out, click on, go to the website and click on the peer-to-peer mentoring program. If you're newly diagnosed and you would like a mentor, go to the same page in our website and fill out an application, and we will match you with someone. And the key thing is, because we are not medical personnel, we will never offer any medical advice. This is really support. It's not, I'm having these symptoms, what do I do for them? It's how to get through living with Parkinson's, it's accepting your diagnosis and having someone to lean on you. You really are frustrated, you don't know where else to go. Next slide. And we have 2 discussion groups online. We have a Tuesday morning every week, open to anybody, and just email Shelley Savoy if you're interested. And our singles group meets usually on Sunday mornings prior to our regular meetings. So it's kind of once a month right now, and it just depends on when we have a program going on. We got to figure out a regular time for them. And next slide, I think that's it. So let's turn off the recording. And if anybody wants to stay on and talk for a few minutes.